So, but the standard, the main way we train in DBT is the intensive training course. So this is a 10-day training course. You apply to participate only as a team. You cannot do an intensive by yourself. You have to come as a team, because DBT is only given in a team, right? Part 1 is 5 days of didactic training with lots of practice exercises for strategies, a lot of exercises to develop your team, to develop your program over a 5-day period of time. You give them 6 to 8 months to do a lot of homework, which they complain about nonstop. Reading, they have to take an exam, they have to practice all the DBT strategies. There's an individual set of homeworks for practicing and a team set of homeworks for practicing. They have to develop their program, they have to write it up as a presentation, including data. They have to present a case also. And that culminates in coming back to part 2 for 5 days of essentially case-based learning. So all the training really at part 2 is built around the presentations, the cases, the programs, their homework, their exam. We use that as the basis for training. So everything is trained around giving them feedback on what they're actually doing.
And they're getting consultation during the homework period?
No,
No, separate.
standard
Okay.
intensive training, you get on average about 1 to 2 phone calls from the trainer in between.
Okay.
And they're sort of available if you need them, but no. This is the standard course.
And how much does the standard?
So the implementation is the alternative training. This is mostly what I do, which is where you are trying to apply, people are applying as a county or a state or a province. So this is where you're trying to train a whole system. And in that case, before the intensive process of it starts, which is sort of embedded in the middle, you do a kickoff, you do 2 days of orientation training, and my goal is to get everybody in the universe who would have anything to do with DBT that can tolerate, where they can tolerate the backfill to release them, comes to this training. So that as many people as possible have a general idea of what is DBT, what's going to happen, what would be involved in this. And then there's 1 day with the administrators. And we're really still working very hard on perfecting what should happen in this day with the administrators. Everybody's sort of doing it differently. We're trying to trying to do something especially with middle management. Because middle management is usually where it falls apart. So part 1 is 5 days of didactic training, same as usual, except there is monthly phone consultation. It usually starts when the teams form, so sometimes right before the part 1, sometimes right after, depending on the timing of it all. And so you have an hour a week with one of the trainers to consult with you on the development of your program and your cases. I've just started doing the emails. I tell you, Shannon, that has been totally worth it. It is a pain in the ass.
The follow-up telling them what to do.
Oh, I'm like so mad at you every time I have like this list of emails to write. I'm so bitter, but it's they really like it and it really helps. But I do my consults at 7 in the morning, sitting on my couch with a cup of coffee and a notepad, and so I have these.
You mean like the focus ones, this is what you'll do?
Well, essentially all I'm doing is summarizing what we said and confirming the homework for the next time, but it makes a huge difference in organizing everybody. It's just a lot of work.
It is.
They say the same homework between the part 1 and part 2. They come back for the part 2, then they get another set of homework, and they come back for a part 3.
This is the breakthrough series of IHI. It's funny how we all do.
So,
yeah.
Right, exactly. So things start to look very similar because I think the same things are needed, truly. So when DBT goes bad, here's some things to worry about, okay? So the functions of DBT, remember those 5 functions at the beginning, they're left out and not replaced with something else. So it's not like in FIT where it's getting replaced with an MST intervention or an addictions intervention. So nobody teaches any skills, the problem. Or no one's dealing with the therapy interfering behavior or motivating the patient because there's no individual contact. There's no one-on-one time when a person is sitting with the kid or the parent, or not the parent, the kid or the adult patient, and like saying, how are we going to solve this stuff? How are we going to make you want to do this treatment? There's not a generalization of skills. The system is reinforcing dysfunctional behavior, which you see just endlessly. Or the therapists are burnt out, or they can't work together. There's not a primary therapist. If anybody's working in systems, this is totally critical to DBT. One primary therapist. Complex and extreme behaviors cannot be managed by committee. Okay? There's got to be one player who makes the choice, because there's often 6 ways you could possibly go, and someone's got to make a decision. Preferably, it's the person who is working one-on-one with the patient, and so the patient becomes engaged in this process. So if I'm the therapist with Sarah, and Eric is the psychiatrist, and the two of us are working together all the time, and the psychiatrist is the license on the line but sees the patient almost not at all, and the psychiatrist is trumping what we're doing, you can end up with a very chaotic situation, because I've made promises that Eric's not keeping, and et cetera, et cetera. The other thing is standard behavior mod will not always work. So if you just have a good behavior mod in your facility, if it's too standard, sometimes it just doesn't work with your complex case. And so you need one person to figure out where those adaptations to the standard system are going to be. The system is managing the client rather than teaching the client to manage the system. We talked about this a little bit before. If everybody's running around trying to make the client shape up, it will fail, I guarantee you. The alliance is not with the client. So the key is that the alliance has to be with the client. This is really critical even for kids, that when you're treating kids in DBT, the primary alliance is between the therapist and the kid. And that's one thing you have to negotiate around with things like MST, where there's a strong alliance with the parents, or others, other systems where the alliance sort of starts to do with lots of other players other than the patient. But if the alliance is not with the client, DBT, you might do other interventions well, but DBT won't work, because DBT really relies on that relationship. Non-acceptance that DBT increases agency costs and staff time considerably or substantially. It is expensive, and if you can't accept that and plan accordingly, just don't start. Because I've spent more time starting with people who don't have the money to continue, and it's just defeating to everybody concerned. And everybody thinks DBT doesn't work. It had nothing to do with DBT not working. It had to do with the fact that no one could afford to actually do the intervention. Don't have paper teams. What we mean by a paper team is that you have a consultation team, but they don't actually work together. Leaving out middle management, oh God, this is a disaster. Okay, the people who actually have to manage the clinicians doing the treatment must be on board. There must be contingencies that they can be reinforced. Forget it. People have poor orientation and commitment skills. They don't learn the orientation and commitment strategies in DBT very well. And so what you find out is either the clients are not required to commit in order to enter. So in other words, they're forcing people in involuntarily. Or they're requiring commitment, but in a toxic kind of way that just turns the kids off. So they're saying they're committed, but they're not really committed, or the same with the ACT patients. You see this in ACT programs too. So you've got to get this piece right. And then the last thing is focusing on process instead of outcomes. So I can't believe I sound like Jürgen, but I really, honest to God, have come to the point where if you can get the outcome, who cares about the process, right? So what matters is not how much of the program is in place or how much the kids participate. This is, and that's